Hey folks, Professor Gulliford here. I'm going to do the final exam review sheet. Just want to make sure we covered everything. I looked at it earlier and I'm pretty sure that we've covered it all, but I just want to be sure. I felt bad we didn't have time to actually go over it in class today, but at any rate, here we are, and I will go ahead and just make sure you have all the review sheet information that you need. I'm doing screen share, and now I'm going to go find the review sheet. Does this one have the answers? Yes, it does. All right. So here we go. Mast cells and Th2 cells release what? These are signaling proteins. I'll highlight some of the key things for you of the inflammatory response, and that's cytokines. That is your answer. That was a big deal in COVID. I don't know if any of you were involved in healthcare during COVID, but the cytokines were the key indicators of just how bad the inflammation was. The nerve that innervates the diaphragm, that's going to be the phrenic nerve. And I think that one's probably a pretty easy item for you now. Phrenic nerve, you've heard that many different times. There is a phrenic nerve pacemaker. If the patient cannot breathe on their own, we can use a phrenic nerve pacemaker to stimulate that. The cells that do phagocytosis in the alveoli are alveolar macrophage. Now, that's the same kind of cell in your blood that would be a white blood cell, a WBC, that is fighting off bacterial infection in the blood. In the alveoli, we call them alveolar macrophages. The lung diseases that are dust related, dust in the actual lung tissue, are pneumoconioses. The big one in our world is pulmonary fibrosis. We see so much pulmonary fibrosis in Texas, Oklahoma, and points west, and that is because of the dust that we inhale. Also, coal miners are famous for getting black lung disease, which is a pneumoconiosis. Yeah. For high frequency chest wall compression, that's the vest, by the way. You know, on board exams, they're not going to say the vest because that's a brand name, but the position is upright or seated. Which medical condition is associated with a decrease in pulmonary vascular resistance? Well, the pulmonary embolism resolution, once it's fixed, yeah, that would be correct. But also increased oxygen tension or oxygen therapy tends to open up the blood vessels. The medicine we give for this is inhaled nitric oxide. I might just add that. Inhaled nitric oxide. And there you go. The difference in pressure between pleural and outside the body is called transmural pressure. We don't use that much in medicine, but you know, it's on this test, so I want to make sure you got it. Avogadro's number is the number of molecules in 1 mole of a substance, and there's the number. You'll never need that number in your medical practice, but at least you know what it is. Avogadro, number of molecules in 1 mole of a substance. The carbon dioxide production compared to oxygen consumption is called the respiratory quotient. And let me just add quickly that it is usually real close to 0.8. 0.8. Various lung zones, we've got 3 lung zones. In zone 1, there is no flow because alveolar is greater than arterial, which is greater than venous. Zone 2, we've got arterial greater than alveolar, which is greater than venous, and you get intermittent flow. And in zone 3, arterial is greater than venous, which is greater than alveolar. That's continuous flow. So that's where the best oxygen flow is happening in the lungs, would be zone 3. I don't know what the exact question on the test will be, but that will be a common one, is where's the best flow? It's zone 3. When the breathing pattern in a diabetic ketoacidosis is trying to correct that metabolic acidosis, it is Kussmaul's respiration. That is what that is. It's a rapid, deep respiration. And by the way, the patient's breath smells fruity. Their breath smells fruity. Some people say it smells like nail polish remover. As in acetone, I've always thought it just smells more fruity. Flexibility of lung tissue allows the lungs to expand or accept a volume, is called lung compliance. Mostly we're working to make lungs more compliance, have a higher compliance. But the flexibility of the lung tissue is lung compliance. Air movement that is erratic or choppy in the airway is called turbulent. So the key words there would be erratic or choppy is turbulent. What we're hoping to do is turn that into more laminar flow. More laminar flow. All right. Normal breathing, the airway pressure at the mouth and nose is typically zero. That is, we can move air in and out of the lungs, but at the nose and mouth, it should be zero, which is atmospheric pressure. The oxyhemoglobin dissociation curve has an S shape, a sigmoid shape. That's what has the 60 gets you 90, 60 gets you 90 rule. Differential cyanosis only in infants when they have the following conditions. Pretty much it's patent ductus, what we talked about today, and pulmonary hypertension. So that is pretty much the two times that you get differential cyanosis. Normal value for venous oxygen, about 70 to 75. Arterial, we're hoping for closer to 90 or 95, but central venous is about 70 to 75. Residual volume is the air remaining in the lungs after a maximal exhalation. Now, if that were to say, I don't know what the exact question is, but if it says after a normal exhalation, that would be the functional residual capacity, the FRC. So I thought I better cover both. Which the following is the most accurate way for determining functional residual capacity? It's definitely the body plethysmography. That's the body box. You're going to learn a lot about that. Sometimes we jokingly call it the phone booth because it looks like the patient's going in a phone booth when they go in there. Pulmonary function study for an individual diagnosed with a restrictive disorder will show decreased lung volumes with normal or increased flows. That is FEV1 to FVC ratios. We generally consider restriction if it's less than 80% total lung capacity is going to be considered restrictive. I think I'll highlight that 80% for you. Normal range for best excess is an easy one to remember. It's -2 to +2. The interesting thing, all the lung doctors that I work with, they don't even use base excess anymore. So I wouldn't worry about it, except it's on this test. So -2 to +2 is base excess. Metabolic acidosis shows up where it's a low pH and a low bicarb. That's how you know it's metabolic. If the pH is caused by the CO2, that's respiratory, but metabolic is going to be a low pH and low bicarb. Chemical buffering mechanisms in the body, well, it's to maintain acid-base balance. I don't know what the exact question is going to be, but basically you just need to know that we have all these buffering systems to keep the pH in a safe range. The conducting airways include what? Well, it's everything down to the terminal bronchioles. So it's really everything that does not have gas exchange. If it has gas exchange, that is not going to be part of the conducting system. That will be part of the respiratory zone. What do we call the process of gas exchange at the cellular level? That is internal respiration. Internal respiration. In addition to providing sensory receptors for smell and aiding in speech, your nose does a very important thing. It filters, warms, and humidifies the air that's coming in. The turbinates help in that, and the turbinates are also known as concha. I'm pretty sure that was on one of your, maybe it was on the midterm. One of your tests had that one. Tracheobronchioplasty, I've only seen that done a few times. It's surgery to reinforce the tracheal wall when there is softening of the trachea. That is a very unusual procedure, but you might as well know about it. Airways right beneath the segmental bronchi, well, that's not surprising. They're called subsegmental bronchi. What nerve innervates the diaphragm? It comes from C3, 4, and 5. It's the phrenic nerve. I think we had that item before on this test, and there might be a little duplication. It's just the way that it is when you're doing exam pools. What are some of the most life-threatening emergencies? Well, let's see here. Respiratory arrest for sure, cardiac arrest, tension pneumothorax, pulmonary embolism. That's a good list right there. Those are some of the most life-threatening emergencies that you will deal with as an RT. The tongue-like, that should be your clue, projection from the upper lobe of the left lung What is that thing called? It's called the lingula. The apex of the lung is actually the very tip above the clavicle. That's a little surprising to people that there's lung above the clavicle, but there is. I can actually answer that or attest to that for you because I've seen doctors inadvertently nick the apex when they were trying to put in a central venous line. Anemia is deficiency in red blood cells and hemoglobin. So your hemoglobin level is usually what we look at to decide how bad is the anemia. Arteries of the bronchial circulation originate in the aorta, aorta, and carry blood to what? The terminal bronchioles. Everything above the terminal bronchioles. Hematocrit is the percentage of blood that is red blood cells, usually around 50% or thereabouts. Prothrombin time, that's measuring the time it takes plasma to clot. We always do that test before surgery to make sure the patient is going to clot once we do the surgery. And PTT is the intrinsic and common coagulation pathway. So those two are usually done together. When they order a PT, they almost always order a PTT with it. When the area below the rib cage appears to pull in on inspiration, that is called subcostal retraction. And that's a sign that the patient is in very severe respiratory distress. Accessory muscles of respiration, the sternocleidomastoids. Those are considered to be the most variable muscles in human body. Accessory muscles. What portion of the nervous system is the rest and digest? I always think of Thanksgiving Day after the big meal, hit the couch, watch the football game. It's the parasympathetic nervous system. Way different than the fight or flight system that when we're running from a bear. Okay, the electrical system of the heart is the SA node and the AV node. I think we covered that pretty well when we did our lecture on that. Almost done here. Cardiac output, we showed you the actual calculation. I don't know if those will be the numbers that you get or not, but cardiac output is heart rate times stroke volume. That's how many beats times how big is each beat, and that gives you cardiac output. Cardiac index is very low, like 1.8. That's going to be a sign of cardiogenic shock. They could also said cardiac output that's very low. That would be cardiogenic shock. The units of cardiac index, liters per minute per square meter. That was on my actual board exam. Amplitude of the heart's function. We place these leads around 3 locations called Einthoven's triangle. Einthoven is the guy I sent you the picture of who was in the first EKG machine. No synchronized contractions. That should tell you everything you need. If there's no synchronized contractions, that's VFib. Risk factors associated with torsades, prolonged QT, hypokalemia, hypomagnesia, and certain medications. That's for torsades. That's that heart rhythm that gets progressively bigger and smaller. What germ layer leads to the lung, the formation of the lungs? It's the endoderm. We just covered that today. Normal tidal volume, 6 to 8 milliliters per kilogram, which is about 15 to 20 milliliters per breath. That is teeny. You guys breathe about 400 or 500, I would say, most of you, as adults. But the newborn, is about 15 to 20 milliliters. There it is. If you know all of that, watch this video a couple times, then we've covered everything you need for the final exam, and you've done very well in this course. I'm going to go grade whatever work is there, but the semester ends this Thursday. So be sure to submit everything you want included in your grade by this Thursday, which would be 6, 7, 8, 9, the 9th of October. Seemed like this semester went way too fast to me, but I will see you in the next course. And I believe that starts, I believe there's a 1-week break, but I will see you in the very next class. I'm here to help, rooting for you. I'll be with you all the way to your graduation and your RRT.